and welcome to another edition of Bringing Hope to Alzheimer's. I'm Anne Fraser, and I am sitting here with Lindsay Ingle, and she is with Brighton Hospice. So tell me a little bit about Brighton Hospice. I know there's a lot of hospice companies. Right. Tell me about Brighton, what you do for them, and what makes Brighton such a great hospice company.
Yeah, so like she said, I'm Lindsay Ingle. I'm the Director of Marketing for Brighton Hospice of Kansas and Missouri. We are newer to this area, but we have been around for about 12 years in 11 different cities.
Okay.
We are hospice RN owned and operated. So she really had a vision for what she wanted hospice to be and where community standards were just not quite there. And so she went out and created her own thing 11 years ago. And here we are growing and opening new sites all over. But as a whole, Brighton just really offers a more robust care model. Every single hospice that is out there gets reimbursed at the exact same rate. Whether they're nonprofit, for-profit, it's all reimbursed at the same exact rate. So really the question is, what is the company willing to do with that reimbursement to reinvest it in their patients? And I think Brighton really does a great job of ramping up the amount of visits that we're able to do. We're able to give CNA visits up to 5 days a week, which is amazing, especially for your home patients that are going through some caregiver burnout and really struggling with that piece. Nursing visits typically start at about 2 to 3 times a week. We have all the fluffy stuff, the massage therapy, the aromatherapy as well. But I really think that our biggest focus is on the amount of care that we're able to give.
Okay, wonderful. And what is your role with Brighton?
So I am the Director of Marketing. So my main role is to create the relationships in our community, open up new referral sources, and also meet with these patients and their families to educate about what hospice is versus what most people think hospice is, and also making sure that their goals align with our goals and get them the care that they need in a really quick amount of time.
Right. So with my, with my parents, we brought hospice in. Hospice was with us for about a year.
Yeah.
And I know that a lot of people feel like hospice is brought in at the end of life, like the last couple weeks or last month, but actually that should not be the case.
Right.
So tell me a little bit about why that should not be the case.
So, years and years ago, that used to be hospice. Hospice was, those last few days, those last few weeks. But Medicare has really seen the benefit of reducing those hospitalizations and getting involved in these patients' lives sooner, rather than when it becomes an emergent situation. So I always say if I could go and change the word hospice tomorrow, just to take that stigma away, I would. Because when you hear that word, there's an immediate trigger that happens, especially in our older generations that's what hospice was. But now there's just so much more to the benefit and getting involved earlier, rather, like I said, when it comes to these emergent kind of chaotic situations, it's so much better and the journey looks so much better, and we're able to almost see kind of an uplift of our patients because they're receiving the care that they want. They're staying in their homes, which reduces the ability to maybe, catch something else that's in the hospital that just kind of sends a tailspin after tailspin. Everybody thrives in their own home and in their special environment. So our goal to keep them there, we do see patients that stay on for a year or longer, as long as their main diagnosis is showing that there's still a decline there, that it's still progressing, we can keep these patients on a lot longer.
Yeah, that's so important. Hospice was fantastic with my parents. They had social workers that would come in and check on me as the caretaker.
Right.
And they came in and brought different activities for my parents. And it was Christmas time, and she brought 3 books because there's myself and my siblings, and brought 'Twas the Night Before Christmas because my parents were still able to read that story and record their voices. So it's just, hospice does a lot of really great things that helped us as a family.
Absolutely.
And kind of held our hand as we walked through that journey.
Right.
Let's focus in now on dementia, Alzheimer's, all dementias.
Right.
What would you say is the largest percentage? I mean, what is the percentage of people that you guys are involved with in hospice that have some form of dementia?
Whew. Quite a bit, to be honest. I feel like there's always something else going on similar to your parents. There was cancer involved, but I see it more often than not. And
so 50%, 80%?
maybe around the 75%
Okay.
have some form of dementia that we're deling with. Yeah.
Okay.
Yeah, and that might not be their main diagnosis.
Sure.
But it definitely adds in how to care for that person, how our approach is, when our CNAs are coming in and maybe that person doesn't remember who they are. There's a whole new approach that has to be brought in with how we care for them. And so to take those kind of things into consideration is super important.
Okay, good.
Yeah.
Do you guys have special training that you go through that really helps? Because dementia, I know firsthand, but for most people, if they've not really sat down and because someone with dementia will tell you, oh, I feel fine,
right,
but they're wincing, right, or, so what kind of training does the staff go through, and what do you see as far as that being able to help in dealing with loved ones and with family members with dementia?
Right. So there's a lot of different trainings and ongoing education that comes in to play. We're looking for we train on looking for facial grimacing. We're looking for different body language with those patients. We do with a lot of our dementia patients, we deal with a lot of refusals of care. We're working through talking through those situations. How do you create that trust with a person that you're almost having to introduce yourself to every time you see them? How do you create that trust? Because those cares have to be done.
Right.
We can't have a missed visit every single time. So working through those challenging situations and then knowing how to not trigger certain behaviors. All of that is ongoing. And it's repetitive, but it works. There's even a component where taking into consideration our VA patients who maybe have really been through some life-altering experiences. And how to work through that. I'll never forget, we had a patient that was triggered by seeing the nurse's bag. The nurse had this big bag. He was triggered because to him, when we got the background about, where he had been, he was triggered by seeing that bag as a body bag. And so he was right back into a war scene, and we didn't understand what it was until we got to the family. We said, hey, this is what he thinks that is. And so working with our team, let's leave our bag outside the door. Let's work on whatever doesn't trigger this patient and allows us to care for him best. Right. So there's just so many little nuances, and every patient is different. So if you have a kind of a standard of what it should look like or different, tools in your pocket to get through those situations, it's the best for everybody.
Right. That's good. I love to hear about that because it is such a different demographic, so to speak, than someone that is aware of what's going on and understands pain and understands where they're at. Because that's kind of the big thing is for people to call in hospice, like we said, people think that means it's time, your time is over almost.
Right.
How long do you guys typically, in a perfect scenario,
right,
someone is ill, how long would you get involved and stay involved? Because let's say it's a terminal illness, whether it is Alzheimer's, dementia, coupled with something else.
Right.
What's a perfect scenario for you?
So regulation states that if a person is given a terminal diagnosis, it's a 6-month or less prognosis. However, none of us have a crystal ball on what that looks like. So I can say that someone has 6 months tomorrow and a year and a half from now, they're still here. We have kind of a research period that goes every 90 days. And so we have to just look at our documentation and say, yes, this person still qualifies.
Okay.
Best case scenario is when we're with these families for that 8 to 12 month range. That's the best case scenario where things are still progressing. We're able to give the patient time. We're able to give that family time and really prepare them for the end of life giving them all the quality that we can, keeping them in the home and versus the hospital stays, the skilled rehab stays, rinse and repeat. That's what we see 9 times out of 10 with the patients that we get referrals on, is they've been through so much by the time that they get to us that they're just tired. And so is the family. The family's providing the rides back and forth. They're sleeping on the couch in the hospital. They're all tired. So let's wrap our arms around them and let's give them the best the best time that they have left. But that 8 to 12 month, I feel like you can accomplish so much. And all of our team gets to be there. They get the social worker, they get the chaplain, they can add on some of, the massage therapies and that kind of stuff during that time. But when you have that quick 2 weeks, you're trying to fit all of those visits in such a short amount of time, and everybody's trying to say, everything that they need to say and get out before, and it's not enough. It's not enough, and it breaks your heart sometimes.
Right, right. With people who have dementia and Alzheimer's, what is because as we know, that's a family disease. It's affecting the entire family. Most of the people that you see have a loved one sitting alongside them who's able to help talk about what's going on and able to really give you, this is what they've been doing, or do you see people that they don't really have someone in their family?
For the most part, I'd say the demographic of this area, we do have a lot of caregivers, and there's at least one. There might be siblings that live out of state, but there's one primary caregiver for the most part. There are those ones that just don't, they have the building that they live in, and that becomes their family, and that becomes their voice, which is, it's sad. But those are almost the ones that need us even more.
Yes.
Because you do become their family.
Right.
But I'd say the majority in this area, in particular, we see that they do have that caregiver, and there's a piece of that where with this specific diagnosis, we have to deal with those families in a different way, because some of them are already grieving before that patient even passes. They're grieving the loss of mom knowing who she is. They're grieving these losses of not remembering, significant milestones. They're already going through that grieving and loss process before that patient goes. And so there's a lot of support that we can give that caregiver prior to, if we're able to get in there earlier.
Which is what we experienced,
right?
Which was fabulous. So wonderful. Anything else you want to say about hospice care?
I would just keep on hammering that, breaking the stigma of, the H word, and really encouraging those who are going through especially, diagnoses like dementia and Alzheimer's, to reach out and just get that piece of education. Anyone can call a local hospice company just to get that information. It does not have to go through a doctor. It does not have to go through the hospital for you to be able to pick up the phone and just ask questions. Paint the picture of what's going on in your home, and let's see how we can help. Whether it's hospice services, home health, palliative, there are a lot of community resources that we're all connected to. So that would be my encouragement, is to let's get past that H word and find out and dig for what it really is, and find out what's available to you.
Right, because it is actually easing the burden for the family and the loved one, because like I said with my parents, just being able to make my mom more comfortable, because she was not able to say she was in pain, but she was in much more pain than we actually realized until hospice got involved. So thank you for what you do. It's very needed. It's not always the kind of situation where you want to meet people, but it is very much needed. And I know you guys do a great job over there. So
well, thank you very much for inviting me.
Absolutely. All right. We will see you all next time. Thanks so much for tuning in.